So right here. So we're talking about the types of neuroglial cells, right? These are 4 easy questions I could ask. 4 easy, up to even 5 easy questions, right? So these questions wouldn't be tricky. Which type of cells are going to myelinate in the central nervous system? Oligodendrocytes. Which type of cells produces or filters and helps produce cerebrospinal fluid, right? Ependymal cells. So that's what we're looking at here. So make sure these, when you're studying these are what we call high yield material, right? That if you get, you can, I mean, if you take a look at this, that's 5, 6 questions I could ask on the different type of cells that we find: astrocytes, microglial, ependymal, oligodendrocytes, Schwann cells, even right here, right? Those are, I mean, that's a lot already that you could get right, just or wrong, just by memorizing those few slides and specific points about those. All right. So just keep that in mind. When you're reviewing this, make sure you're reviewing it in a very systemic, really type of a scientific way. All right. Now, satellite cells, Schwann cells, astrocytes, know little bits about those, right? I'm not asking you to do a research paper. Simple things like astrocytes helps form the blood-brain barrier. Perfect, right? That's important. That's very concise, right? It's not something you have to really expound about and talk about in super great detail. Right? It helps form the blood-brain barrier. That's an important concept to get. The blood-brain barrier, we're going to see later on in the next couple slides or next couple chapters, right? The blood-brain barrier is very important in protection, and it can be a hindrance as well. So it's something that the actual medications we give have to cross so then it can actually go into the brain and do its job. So some medications don't cross the blood-brain barrier. Some more easily does, right? The weird thing is some of the recreational drugs we use actually crosses the blood-brain barrier pretty easily, right? Even alcohol crosses the blood-brain barrier pretty easily. That's why just a small amount can cause people to get drunk sometimes. Small amount of marijuana can do that as well. So yes, marijuana does cross the blood-brain barrier. Now, when we talk about myelin sheathing, that's usually what we talk about at the very end, right, of last week. Myelin sheathing is a fatty coating that we wrap around our nerve, the axons of a nerve. And what happens then is by wrapping around the axons multiple times, now you have a physical barrier in that region. No nerve impulses or action potentials can be triggered because nothing can get through in the region that's wrapped, right? There's too much fatty wrapping around it. So that by wrapping the cell right here, so here's the cell, here's the axon coming out of a neuron, by wrapping parts of the neuron, parts of the axon with this fatty coating, what happens is the area where we have this fatty myelin sheathing, well, we can skip those areas. And those areas don't undergo an action potential. So what happens is you have an action potential, a nerve impulse, that's going to be triggered at the very start of our axon, and then it's going to skip to other bare areas. As it skips to the bare areas, what's going to happen then? Well, you're going to speed up that action potential, speed it up so much that we can actually start controlling things. And even worse, and we know this happens, right? Certain diseases like MS affects the myelin sheathing. And just by affecting the myelin sheathing, what occurs is you slow down the action potential, because regions that we should skip over, well, those regions now we have to wait for them to undergo a nerve impulse, right? So instead of skipping, we have to go through this whole area, right? Instead of skipping this area, we have to go through the whole area. And what happens is you slow down the nerve impulse so much that it slows down and stops, right? And this is how even a pinched nerve can cause us to have loss of sensation, loss of function, right? So myelination right here, lots of facts. It's one of the main reasons why we never want to have to, replace breast milk with cow's milk too early. Even if we use whole cow's milk, right? The last thing we want to do is replace cow's milk, mom's milk with cow's milk. Whole milk does not have enough fat when compared to breast milk. So never, even though for us, whole milk is pretty thick, right? It still doesn't have enough fat content. And because whole milk doesn't have enough fat content, well, we need that fat so then we can myelinate after you're born. Right? Now, myelination begins early on, but it doesn't really accelerate until you are born. Right? Fats have a much harder time going from mom's circulation to baby circulation. And what happens then is most of the actual true myelination of our neurons occurs after birth and infancy. Right? And most of the fat that we use to form the myelin sheathing is there because of how much fat we ingest. So the more fat we ingest, the better it is, right? Now, if you look at all mammals, it doesn't matter if it's a chimpanzee versus an orangutan versus a dolphin, right? So all mammals have very fatty milk. The reason for it is because it allows us to myelinate. So that's one of the cool things that we see, that we can actually kind of take what we know, translate it to other mammals. And when we look at the milk in the mammals, same thing, right? Lots of fats. And in those animals, they myelinate as well. Now, in the peripheral nervous system, right here, Schwann cells wrap around one part of one axon completely. The more complete and thicker the wrapping, the more you're going to bypass that area with a nerve impulse, right? So this action potential, what we're going to go in line and trigger more action potentials in the next sequence, right? So if you have an action potential here, you should have one next to it. You should have one there. You should have one there, all the way down this line. Now, again, right? That's slow. It would take too much time if we have to go through the entirety of the axon. So how do we make it faster? Well, we make it faster by allowing us to have multiple sheathing on the axon and then bypassing all the areas with the sheathing. So only the bare areas undergo action potentials. So you skip around from one bare area to the next. Each bare area is called a node, right? So the nodes around the A are gaps between the segments. That's these guys right here. So a node is the uncovered gaps between the myelinated segments. And we're going to see that we will have action potentials or nerve impulse only in the bare areas. The other areas that's myelinated, we skip over. Now, I used the analogy in my 201 class of driving to Chicago versus flying to Chicago. Anybody's ever flown to Chicago? It's pretty fast, isn't it? By the time you sit down, right, 5 minutes later, you're ready to land. It takes more time to get to the bathroom and come back, right, than to go sit down. And then by the time you get in the air, it's just about time to land. The reason for it is simple, right? When you're flying, you're going faster, right? But you never go at high altitude because you're not going high, you're not going far enough. So you're bypassing all that strip of land, right? From Milwaukee to Chicago. You don't have to stop at any tolls, right? You are going from one node to the next node. That's it. You bypass all that space in between. When you're driving, you can't bypass. You got to drive every single meter, every single kilometer, every single mile until you get to Chicago, right? That's why it takes so much longer. So if we had an unmyelinated axon right here, what we will see in an unmyelinated axon is that unmyelinated axons, right? We will see that here, right? We'd have to go through the entirety of the actual axon. Not good, too slow, right? By myelinating, now we have a physical barrier, right? We can't have an action potential in the areas where we have a physical barrier. So you bypass that area. It's like flying from airport to airport to airport. It's going to take so much less time, right? Now, understand that in terms of myelination is slightly different in the peripheral nervous system versus the central nervous system. The cells are different, right? The concept of skipping things over, that's the same, right? We're going to see that in the peripheral and the central nervous system. But the cells that allows us to form this boundary, this barrier, right? In the peripheral nervous system, it's called a Schwann cell. In the central nervous system, it's called an oligodendrocyte. With oligodendrocytes right here, right? Oligodendrocytes right here, they can and they do, right, myelinate several nerve fibers at one time. Whereas the Schwann cells only myelinate one segment of one neuron. That's it. All right, oligodendrocytes right here. Here's an oligodendrocyte in the CNS. It can wrap around multiple axons at multiple sites. Now, it's good because it can do more, right? It's covering more space versus one cell covering one part of one axon only, right? The bad thing is it's not a complete tight covering, right? It doesn't cover as completely as Schwann cells does. All right, so understand that concept of skipping around right here. Oligodendrocytes myelinate several nerve fibers in its immediate vicinity right here. Sorry. In terms of myelin sheathing, right? The nodes right here, understand what they are, right? These nodes right here are gaps between the segments, and this is where action potentials are triggered, right? So only in the nodes do we see the action potential. The internodal area are areas that's covered by myelin sheathing, right? Those areas are bypassed. Remember, it should make sense, right? In order for an action potential to occur, we need sodium to come in from the outside into the cell. Well, now you have a barrier in the way, right? How is that ion going to get through? It's not, right? So only the bare areas that we call the nodes around VA, only those nodes do have action potentials. Right? Now, the initial segment right here is a part of the axon between the axon hillock and the first glial cell. Now, within it, I want you to know the trigger zone right here, right? That trigger zone is going to be what allows us to start the action potential, right? It's called the trigger zone for a reason, right? This is where action potentials are triggered along our axon. So what do we mean? Right here, when we look at, right, our axon right here, here's our cell body, here's the axon. This area is called our trigger zone. When we stimulate this neuron as part of a pathway, it gets stimulated. We want an action potential to get started at the trigger zone. Then it's going to skip to the next node. Then it's going to skip to the next node, skip to the next node. By skipping all that space, you bypass it, you make the speed much faster, right? Now imagine, what would happen if you were driving and there's a slight delay in your optic nerve, right? Just even a slight delay. Well, when you're driving and there's a slight delay, you're not receiving as much input as you should, right? Driving will be a disaster. So we want speed. The faster the action, the potential, the better it is. And this allows us to have faster action potentials right here by skipping. Now, some of the diseases you need to know, one of them that we already mentioned, MS, right? MS right here It's a degenerative disease. And just like all autoimmune diseases right here, right, it affects a lot of women, much more than men. Sorry. All right. So when we talk about MS, it can affect the Schwann cells. It can affect the oligodendrocytes. Either ways, though, the M and the S in multiple sclerosis, I want you to think the other parts, myelin sheathing. M&S, M&S, right? Multiple sclerosis, myelin sheath, right? So when we see the actual MS in people, right, and usually women, we're going to have the myelin sheathing being attacked by your own by your own body. So this is an autoimmune disease, and it's usually triggered by some kind of viral infection. Then we produce antibodies to the virus. As we produce the antibodies to kind of neutralize the virus, what occurs then is that the antibodies starts to mistake our myelin sheathing for the virus, and it starts attacking the myelin sheathing. When that happens, you start having MS, right? Now, it's basically a very degenerative, progressive disease. Hopefully, we can slow it down enough. Sometimes it just kind of causes a person to deteriorate, right? Nerve conduction is disrupted because of myelin sheathing is then affected. And remember, when things slow down, what occurs is going to stop. The action potential stops then, right? Onset between 20 and 40 and fatal right? After 25, 30 years of diagnosis. Now, we do have other medications that are better nowadays that can hopefully regulate it, but eventually your phrenic nerve that allows us to activate your diaphragm starts to slow down. And when that happens, right, it can cause people to make a bad choice, right? The bad choice is simple. Do you want to live on a ventilator when you're 75, 80 years old, right? Most people choose not to, right? But without the phrenic nerve activating your diaphragm, you can't breathe by yourself anymore. So that's what death usually happens and how it happens, right? So conduction speeds, right? Speeds at which the nerve signals travel along the nerve fiber, dependent on two things. So again, speed is important. So two factors in terms of how fast we can conduct a nerve impulse or an action potential, right? One, diameter of the fiber. The larger the fiber, the faster the nerve impulse. And then presence or absence of myelin sheathing, right? So presence, if I have to go and walk from here to the door, do I need to run? Not really, right? It's a very short distance. So if I have a very short distance to travel, there's no point myelinating. That's just a waste of energy, right? Now, when you have a very long distance to travel, say your sciatic nerve, what happens then? Well, myelinating will speed up the action potential to the point where you can trigger muscle contractions, all right? So we want speed there. So we're going to have a fully myelinated, really tightly myelinated type of nerve cell for the sciatic nerve. Whereas for what we call interneurons that are very, very short, guess what? We don't need to waste that fat to myelinate. So there are, in other words, some neurons that are not myelinated, right? Now, signal conduction occurs along the surface of a nerve fiber. Myelin further speeds the nerve signal. Large fibers have more area for channels, for gates, right? And what happens? The more channels and gates, the faster we go. Anybody's ever gone to Chicago and then they have to wait for somebody, right, to throw their money into the actual tollway? Nowadays, they make it easy so that you don't even think about it anymore, right? But I remember when I first started driving to Chicago, it was like 25 cents for the tollways. Now it's like $2, right? If you go to New York, I mean, some of those, tolls are crazy expensive. $20 to go on a bridge one way, right? Crazy, right? So they don't want you to take out that money nowadays, right? Why? Because if you have to take out the money, give it to them, you'll realize how much you're paying. Secondly, if you have to physically give them the money, what happens? It slows everybody down because everybody has to stop. They have to interact with that person. You got to get the money out. You got to get the change. Then they lift the gate, right? Slows everybody down. So what do? Instead of the person, we have a little RF reader, right? That allows you to then use that, iPass, so then you can go quickly and more people can go through, right? By having a larger diameter, you have larger room for those iPasses, right? And more cars can get through. More cars, more money for them, right? So this is very similar. The larger the diameter of the fiber, the more ions can pass through, the faster you can speed up an action potential. And again, speed is important because remember, any delay, right, can cause you to either miss something or it can actually prevent contraction, right? Conduction speed. Now, again, I'm not going to expect you to know the actual speed. What I want you to know is relatively what happens, right? Small unmyelinated fibers are the slowest. Why? Because just by not having myelination, we know you're going to slow things up, right? Even worse, the smaller it is, the less room for ion channels. And it's ion channels that open up that allows action potentials. So if we have a small unmyelinated fiber, you have the worst of both situations. Unmyelinated, very small fiber, not a lot of room for ion channels, right? It's going to go from 0.5 to 2 meters per second. The fastest ones should then be large, fully myelinated, right? And that's what we see here. And again, I don't expect you to know the numbers, right? I want you to know the actual relationship, though, right? Large myelinated fibers, right? Best of both worlds. Fully myelinated, large space and diameter, so then you have more ion channels. Faster you can go, right? Slow signals supply the stomach, dilate the pupils, where speed is less of an issue, right? Fast signals supply skeletal muscles and transports and sensory, right? Basically, fast signals supply skeletal muscles and sensory signals, like the optic nerve, right? For our sight. Now, fast signals supply skeletal muscles for a reason. And the reason is simple. We were never, even now, if you go into, right, Alaska and you're not carrying a gun, you're going to have bears there, wolverines there, right? Even moose are very dangerous, right? So yet, and even deer can be very dangerous and attack you. We're not very strong physically. We're only strong because we have guns and we have ammunition, right? That basically cancels all the other effects of our, right, kind of relatively weak body. So if we are not that strong just as a person, we need to be able to run away, right? If we get into any kind of trouble. How do we run away? By activating skeletal muscles. The faster we run, the better, right? So we want to activate the skeletal muscles so that we are the first to get out of the way, right? You don't need to be the fastest. You just can't be the slowest. So yes, we need to send those signals to the skeletal muscles, and it has to be fast. Now, in a synapse, right, a nerve signal can go no further when it reaches the end of the axon, right? What happens that where a nerve makes contact with another nerve, where a nerve makes contact with a skeletal muscle, what we're going to see is you have this actual release of a neurotransmitter onto the next tissue in our line, whether that tissue is another neuron, whether that tissue is a gland, whether that tissue is a muscle, right? Now, we never have a physical contact point. So you never have a nerve makes physical contact with another nerve. There's always a little space called the synaptic cleft right here, right? So in the synaptic cleft, we're going to see right here, right? This postsynaptic neuron, which is the one we're going to activate or inhibit, the one we're connected to, right? This postsynaptic neuron right here is going to have channels, ion channels, right? Receptors for a neurotransmitter I'm going to be releasing. Now, the name neurotransmitter, it transmits signals from neuron to neuron, neurotransmitter, right? Now, we've talked about one already, acetylcholine. Now, if you're on any kind of the antidepressant, then it doesn't matter which one you're on, you're going to be on some kind of a neurotransmitter activator. If you're on Prozac, right, you're on what's called an SSRI, selective serotonin reuptake inhibitor. What it does is it causes increased release of serotonin as part of this pathway from one neuron to the next neuron to the next, right? Now, if you're on something like Wellbutrin, right, you're on a NERI and a combination of SSRI as well. So norepinephrine's release in more frequent pulses, so is serotonin, right? So those are all types of neurotransmitters. Serotonin, acetylcholine, norepinephrine, dopamine. Those are all types of neurotransmitters, right? And all neurotransmitters are going to be released from one neuron to the next at our synapse, right? It's going to cause a stimulation of electrical activity in the next neuron. Now, that electrical activity can cause the next neuron to activate, like when we have serotonin, right? Serotonin reuptake inhibitors will hopefully cause the next neuron to more likely activate, so then we can activate your mood. Or it can also inhibit. Now, some of you guys have heard of Xanax. Some of you guys have heard of Valium. They work on what we call GABAergic, right, receptors on certain types of neurons. Both of them, right, once you release GABA, it's a neurotransmitter, right? The neurotransmitter release from one cell to the next is GABA. It binds to it and the next neuron, and it causes it to be inhibited, right? So what happens is you cause the next neuron to be very negative and you shut it down. As you shut it down, it allows that neuron pathway to be inhibited, slow down, and stop. As it stops, it allows you to, and it forces you to relax, right? That's how Xanax and Valium works. They work on very similar receptors, just at different regions of the receptor, right? Now, when we talk about a synapse, the neuron that's releasing the neurotransmitter is called the presynaptic neuron. This is a presynaptic neuron. It releases a neurotransmitter. The one that's receiving, right? The one that's receiving the neurotransmitter is called the postsynaptic neuron, right? So as part of the pathway, right, we're going to see just this two neuron system. This is a presynaptic neuron. This is a post, right? Well, in order to activate this neuron, we needed another neuron before it. So in this synapse right here, we'll see that it will be the postsynaptic, and then there'll be another neuron next to it that's a presynaptic. In other words, when we look at different areas right here, right? When we look at this synapse, this is a presynaptic, this is a postsynaptic. But when we look at this neuron and follow it all the way down, now this neuron's a presynaptic neuron right here, and the next neuron is a postsynaptic. So by looking at different synapses, you can have one neuron be presynaptic on one side and postsynaptic on the other side, right? Now, the main neurons we're going to talk about, we've already seen. There's about 100 of them, right? Acetylcholine is the one that's released by the actual motor neuron, and it causes your skeletal muscles to activate, right? Acetylcholine, know what that is? And then I'm going to have you memorize a group, right? A group of them called monoamines, right? Now, who's ever watched TV in the middle of the night and you hear a commercial, they're like, yeah, if you want your mood to be lightened, you can buy this medication, right? And they really kind of touting how great it is. And then at the very end, it says, do not take this medication if you're on a MAO inhibitor, right? A MAO inhibitor inhibits all these monoamines. The monoamines are epinephrine, norepinephrine, dopamines, right? Now, I'm going to show you what they look like. And they're going to see that for the most part, they look very similar to each other, right? So here's an image of all the monoamines. Right here, right? So, right, this one is a little too much, right? Right here's a good one, right? So here's serotonin, here's dopamine, here's norepinephrine. Look at how similar dopamine is with norepinephrine, right? The only difference is this hydroxyl group, this OH group sticking out right here, right? Serotonin is slightly different, but epinephrine, norepinephrine, they look very similar to dopamine right here. Now, we call these monoamines because it has one nitrogenous group that we call amine here. It only has one of the amines. One amine here, an amine here, amine here, right? Now, all three of these, and even epinephrine, right? All of them are deactivated by the same hormone or the same enzyme, right? And that enzyme is called monoamine oxidase, MAO, right? So when you hear somebody say, or a commercial, and it says at the very end, do not take this medication if you're on a MAO inhibitor, the reason for it is this. If you're on a MAO inhibitor, you're inhibiting the enzyme that is meant to deactivate serotonin, dopamine, and epinephrine. By inhibiting that enzyme, you're going to have already, by taking the medication, increased amount of serotonin, right? Because the enzyme that should get rid of it, well, we deactivate it. So your serotonin levels are going to go up because we deactivate that enzyme, right? By taking that MAO inhibitor, right, we no longer deactivating dopamine. So dopamine levels will increase. So will norepinephrine. So by taking a MAO inhibitor, right, you're going to have a slight increase in all three neurotransmitters already. What would happen if we're taking a MAO inhibitor and all of a sudden we take Prozac with it? You're going to have a sudden massive increase in serotonin, right? The first one, right? You're already a MAO inhibitor. Your serotonin levels are a little bit more elevated than normal. And now you're taking Prozac, which selectively increases serotonin levels even more, right? You have a massive sudden increase in serotonin, right? It can cause people to have suicidal ideations, people to commit suicides. That does happen, right? That's why you hear the commercials now. If you have suicidal ideations, do not take that medication, because we did have many people that did commit suicide or attempted to, right? After taking Prozac, right? Now, oh, so those are monoamines right here, a type of neurotransmitter class that are inhibited by monoamine oxidase. Functions of the neurotransmitters at the synapse, they're synthesized by the presynaptic neuron. They're released in response to stimulation. They alter the physiology of the next cell by binding to a specific receptor of our next postsynaptic cell, right? Now, we're trying to be a little bit more broad, right, when we discuss this than normal in like a 179 class, right? So 177 should be just the anatomy. The problem is talking about purely the anatomy, we have to find an actual cutoff point, right? So if you read the chapter 11, 12, 13, these are huge chapters, right? So what I want you to do is use the PowerPoints as a guide to what you should be reading in those chapters, right? So this is that. That was sorry. So Here's our spinal cord right here. And again, I showed a video before and it showed just how soft the brain is. Now imagine your spinal cord right here, and it's just one small part, like one of the gyri of the brain, right? So it's incredibly small. We do have a lot of bones to protect it with the spinous process, with the vertebrae protecting it in both sides, but it doesn't take a lot of trauma to cause an interruption of the spinal cord. By the way, when people get spinal cord trauma, you don't have to fully separate it. Just a sudden violent movement, right, can interrupt that actual nerves as it exits out. Now, example of this, have you guys ever somehow bought like a really long Apple iPhone cord, right? And it's super long, you're like, this is great, right? I can charge my phone from anywhere. You bring it in the car, next thing you know, you take it in the car and you're charging in the car and you don't really notice until you leave the car and you close the door on the cord, just how a long cord can actually be bad. And once you close the door on the cord, you realize that it doesn't work anymore. Why? Is because you didn't really, completely separate the cord, but you did enough damage to the wires under the cord that now electricity can't flow through. And now you can't use that cord anymore. Same thing here, right? You don't need to physically chop up the spinal cord. All you need is a small trauma, interrupt it long enough for you to cause damage, right? So just when we talk about spinal cord and spinal cord trauma, we're not talking about a complete cut of the spinal cord. That's very rare when that happens. But that can cause you to have spinal cord trauma. Most of the time, it's just a minor issue where you land wrong, right? Or somebody hits you in the wrong spot in football, right? And what happens is you just have that sudden motion where there's a jerking sensation, right? And that's enough to interrupt the nerves underneath. And now you have spinal cord trauma, right? So when we talk about spinal cord trauma here, we have paraplegia and quadriplegia, right? Paraplegia is a paralysis of your lower limbs. Usually we see people in a wheelchair, they still have control of their upper limbs. Quadriplegia is when people have basically paralysis below the neck, right? Now, usually with quadriplegia, the most dangerous type that we'll see is when the respiratory system, right, no longer starts to work. So anything below your C or above your C5 vertebrae. So if you have spinal cord trauma above your C5 vertebrae, so we count it, right? C1, 2, 3, 4, and 5. C1 is your atlas. C2 is your axis, right? C3, C4, C5, right? Anything above that C5, if you have spinal cord trauma that high up, not only will you have quadriplegia, not only will you have loss of sensation, you will also have loss of breathing functions, right? When that happens, again, another difficult choice, right? Do you want to be on a ventilator the rest of your life? Do you want to live on a ventilator when you can't move your body and you can't have any sensations either, right? So these are all tough choices we have to make. And once you make that choice and you want to live, and they put the tube in your mouth and ventilate you, it's almost impossible for them to allow you to remove that tube, right? We do not allow for assisted suicide in America. So it's almost impossible for you to, after 10, 15 years living like that, some people choose to not want to live in that way anymore. So they want the ventilator out so then they can peacefully pass away. Well, once you put it in, the ventilator, you have a very hard time convincing the court to remove it. All right, that does happen, but it's incredibly rare. Right now, damage to the spinal cord also cause us to have loss of sensation. So this is just talking about paralysis. Paralysis is a loss of movement, right? Now, when we have a damage from a stroke, we have hemiplegia, where one side of the brain controls the other half of your body. So if you have a stroke on one side of the brain, right side, right, specifically in the right frontal lobe area, you're going to have hemiplegia, right? Where you have paralysis on the opposite side of the body. Next, right? What are the functions of the spinal cord? One, conduction. Second, locomotion. And then we're going to see spinal cord reflexes. Conduction is the movement of a nerve impulse down the brain, through the spinal cord, down and out through the rest of your body, right? So we can conduct an action potential or a nerve impulse from your brain all the way down and then out to the target muscle or tissue. That's what we mean by conduction, right? Now, all intended motor movements start in your brain. Intended, right? Reflexes are slightly different, but all movement with intent starts on the other side of your brain. Let's say I'm writing with my right hand. All that movement starts in the left area of our brain, in the frontal lobe. Then we have fibers that goes down, neuron fibers, axons that goes down the brain, crosses over in the spinal cord. Then we have another contact point with another nerve in the spinal cord. And then that nerve sends an axon to my target muscles, right? So that we can conduct the action potential that starts in the brain matter. What else? Locomotion, right? Walking involves repetitive, coordinated movements of several muscle groups. Now, the thing about this locomotion is we have much larger area of your brain for locomotion than even other animals. And the reason for it is simple. We need more balance and equilibrium, right? We're only on two legs, so we don't have as many contact points as, say, any other animal, right? So we need more areas of the brain just for locomotion. And if you think about it, look at all the different muscles we will need just to activate to take a step, right? You need to push off with your quadriceps. You need to relax the opposite muscles. You need the opposite leg. Once you step up, right? You need to put all your body weight on the opposite leg so then you don't fall over. Then you have to transfer that weight so that you can take your next step. All of this happens without you really thinking about it. All you have to do is just think about taking a step. Then your spinal cord takes it over. So then you don't have to think about any more steps, right? Can you imagine how hard it would be to walk if you have to actively control all of the muscles, all right, in your legs so that you can take every step? You will not be able to jog because it would be so much brain power to actively control everything. So we're going to see the spinal cord, certain parts of the brain that are involuntary, that are unconscious. Those areas take over. So when you're exercising and you're doing the elliptical machine, you're not thinking about contracting those leg muscles, each one, right, at a time. You're trying to actually avoid that, right? Because that gets tiring. So you're listening to music, you're watching TV, and you're kind of losing yourself in the exercise, right? That can only happen because we have the spinal cord and we have other parts of the brain that allows us to subconsciously control those movements. Next, reflexes, right? Reflexes are involuntary stereotype responses to certain stimuli. So when we talk about reflexes, we're primarily talking about things that we see all the time, right? Flexor withdrawal. When you touch a hot stove, when you get a cut, you move your finger out of the way, right? That pain reflex to remove your limb from that situation, we call it the flexor withdrawal reflex. So then you can remove your limbs by flexing and then withdrawing it away from that painful stimuli. Now, this involves the spinal cord because if we have to activate the brain, then send that information back down to consciously move, your hand will stay on that hot stove much longer, right? Instead of flexing and withdrawing, and it goes to the spinal cord and back to the muscles. If it goes to the brain then has to be aware of it and then cause a muscle contraction. You got to have your hand on that hot stove for 2-3 more seconds. So instead of a first, second degree burn, you have a second degree, third degree burn, right? That's not good. So we want anything that's painful can to activate reflexes that is going to be triggered in the spinal cord. The spinal cord takes over, so then you can move your hand out of the way before you cause more damage. By the way, this is the reason why when you go to doctor's office and they check your patellar tendon, right, reflex that moves your leg up, by the time you realize that the hammer has hit your knee, your leg is already moving up, right? Well, it's because it doesn't, by the time that actual sensation gets to the brain, the spinal cord has already triggered its response, right? That is there to prevent unwanted actions. Was that? If you don't do that, it can be something wrong with the spinal cord, right? There can be delay reflexes. There are things that we can do to speed it up as well. So we can, especially with a lot of caffeine, you can make your reflex actually hyper if you take a lot of caffeine, right? So we don't want it to be low. We don't want it to be high. We want it to be normal, right? So there's a range. Now, we also have other reflexes that we don't think about. Look what happens, and this is why when somebody gets a concussion, we need to go in a very dark room, right? What we're doing when we have a concussion is called a pupillary light reflex. So in order for that to happen, we need a dark room. Your pupils need to dilate. As they dilate, then what occurs is I'm going to shine light into the pupil. As you shine light to it, right, certain parts of the brain takes over and causes the pupil to constrict. Makes sense, right? Light, you don't want it to damage your retina, so you constrict the pupil so then less light gets through. Now, the one part that doesn't make sense, but is really cool, right? If you have a significant other, I want you to try this at home, especially if you have a pen light, right? This is why doctors do this test twice, right? When you shine light to that one light, the eye, it makes sense that eye that gets the light starts to constrict. Now, the other thing that most people don't know is when I shine light to this eye, the other eye constricts as well. That's why you see them doing it twice, the doctor or the trainer. The first time is to check the direct light reflex. The second time is to check the opposite eye, right? Because when I shine light in one eye, both eyes should constrict, not just one of them, right? Now, I remember when my daughter had a bad concussion and I checked her light reflexes. Her one eye was severely delayed. It wasn't like, oh, it should constrict immediately. Both of them should constrict almost immediately. But her consensual light reflex was delayed 2 to 3 seconds. Immediately, I knew there was a problem, right? Took her to a neurologist the next day. She had post-concussion syndrome for 2 months, right? Where she just couldn't, everything just felt wrong, right? You don't need to have headaches, but you do have this kind of wrongness in you. And that's not a very good sensation to have. It took months before she worked herself out of it. But it does happen when you have a really bad concussion. And that is a type of reflex, a pupillary light reflex. It can involve the brain and the spinal cord. And then, even though we think of your eyes as being close to the brain and the optic nerve as being almost part of the brain, it's not, right? It's part of the peripheral nervous system. All right. I know, right? The spinal cord itself, a cylinder of nervous tissue that arises from the brainstem at the foramen magnum and goes all the way down the vertebrae, right? The inferior margin ends at L1 or a little beyond it. Average is about 1.2 centimeters thick. So you have about 2 centimeters per inch. So this is less than an inch thick. Very fragile, right? Occupies 2/3 of the vertebral column. We have 31 pairs of spinal nerves. So the 31 pairs of spinal nerves exit out. They will mesh, right? And they will network with other spinal nerves to form our name nerves that we'll talk about later, right? So when we talk about a name nerve, like a median nerve, that median nerve doesn't just come from one spinal cord segment exiting out. What we're going to do is we're going to form a series of networks. And we're going to have wires that kind of network with other wires. And those wires that help form our named nerves. Other surface anatomy, right? Spinal cord is divided into the cervical, thoracic, lumbar, and sacral region, kind of like the vertebrae, right? Two areas of the cord are thicker than anywhere else, right? The cervical region, we have a cervical enlargement. In the lumbar region, we have the lumbar enlargement. Now, notice we don't, right? These enlargement allows us to bring nerves, motor neurons, to the upper limbs. Most of the muscles that we have are going to be found in our limbs, whether it's upper or lower limbs. Because of that, right, the cervical enlargement, well, it's enlarged because we have more nerves that has to go through, because we have more muscles that we have to activate. We also have more sensation in that area. So if you get a cut on your fingertips, you know where that cut is, right? Why? It's because there's more sensitivity. How do we get more sensitivity? We have more receptors, we have more neurons going to that region, right? So we have more sensory neurons entering that region as well. If we have more sensory neurons receiving information, more motor neurons giving information out, it makes sense that area has to be larger. So in the areas where we have limbs, we have enlargements of the spinal cord. So it's not just one uniform cord that looks 1 inch all the way through. There are enlargements that make it bigger. Then in your thoracic area, the spinal cord actually gets smaller. And in the lumbar area, it gets bigger again, right? The enlargements coincide with the limbs. At the very end, we have an end of the spinal cord that we call the conus medullaris, or medullary cone, right? This is a terminal end to the spinal cord. That doesn't mean we don't have nerves that exits out. Remember, right? I want you to think of your brain and spinal cord as a highway system, right? You have a highway system that takes you from Milwaukee to Chicago to Minnesota, right? Now, does anybody live on the highway? No, right? To get to your house, you have to exit out of the highway, right? That's where the nerves exit out. So that you can go to the specific targeted area of your body. So we have exit points for the nerves, entrance points for the nerves. So then we can access that highway, right? So that's how I want you to think about this. You have this super highway that can take you anywhere, that has information going up, going down. The information going up are sensory information coming from your limbs, right? You need the brain to process that sensation and figure out what to do. Well, in order to do that, you need to bring that sensation up into the brain to process. The spinal cord has segments, has pathways that allows you to move that sensation upwards, right? Then once you kind of figure out what to do, the brain triggers some kind of motion. So then you can cause either your arm to move in response, or you can trigger your stomach, right, to move because you have food in there. So there's a large range of movements that the brain can actually cause, right? Any kind of movement, though, is triggered by the brain and neurons that come downwards. So motor signals always comes down, sensory signals goes up, right? But we need a way to bring that sensation into the spinal cord. That's where the peripheral nerves come in, right? So in a second, I'll show you what we mean in the actual models right here. So take a look right here. All right, when you take a look, could be a little too big. Right here, right? So we have the spinal cord and the brain. The spinal cord and the brain, one continuous unit, right? Then we have these nerves that exits out. See that? These nerves that exit out is our link to the rest of our body. If these get interrupted right here, right? Up here, if it gets interrupted, we're not going to have sensation from our thoracic area in our shoulder, right? Because you don't have sensory signals going in. You also then will have a hard time controlling your shoulder muscles, right? Because you don't have motor signals traveling out, right? So again, you have these signals that travel up and down. But in order to activate those signals, you need to have a pathway to bring that sensation into the spinal cord. You need a pathway to send the motor signals out of the spinal cord to the muscles. That's where the spinal nerves come in. Spinal nerves allow you to have neurons that exits out of the spinal cord. As it exits out, it goes to your target muscle. So then I have a motor function, right? So the spinal nerves has motor signals that exits out then. Now, you also need sensory signals to come into the spinal cord. So then you can bring that signal up to your brain to process, right? So these spinal nerves are combinations of motor and sensory signals that connects our brain and spinal cord to the rest of our body, right? Now, if we have the brain and spinal cord, they're intact, everything's perfect, but all of these spinal nerves have been cut, what would happen? Right? Again, brain and spinal cord working perfectly, but some reason or another, your spinal nerves that exits out here can no longer exit out. What happens is you can't send sensory signals in at any one of these levels. You can't see, send motor signals out. You would be paralyzed. You would have loss of sensation. All right. That's how important these spinal nerves are. They allow you to send signals to your muscles so you can move. They allow you to send sensory signals from the limbs so then you can feel, right? If it wasn't for these, all the signals would be trapped right down the middle of your spinal cord. Powerful, but useless, right? Next, meninges. Now, I'm going to show you on Anatomy and Physiology Revealed, the meninges themselves are protective and how they're protective. So meninges are an extra layer of protection that we have for the brain and the spinal cord, right? Remember, bone is very sharp. It can damage the brain and the spinal cord. And we saw just a second ago just how fragile and soft the brain is. Would you want that very fragile, soft brain to be resting directly on your skull? No. The inside of your skull is very sharp and very ridgy, right? So what do? Well, what we do is we encase the brain in another or 3 layers of connective tissue to protect it. The most superficial layer is called a dura mater. Then the next layer deeper, arachnoid mater, and then the matter or connective tissue that is closest to the real brain matter is called the pia mater. The pia mater is very, very intimate with the brain. You can't remove it without damaging the brain. So when we saw that video, didn't the brain look kind of glossy, right? It wasn't very dull looking. It looked glossy, right? Weird looking, right? The thing is, it's glossy because we have the brain matter, and then we add that pia mater on top of it. The pia mater makes the brain appear glossy. You can't separate it without damaging the brain, though, right? The arachnoid mater right here is a little bit, right, is the intermediate matter between the tougher dura mater and the more intimate pia mater. Yes. Yeah, yeah. They have to cut into the dura mater. They have to go through the arachnoid mater, and then they'll do little tiny incisions, right? And then use a vacuum to just get rid of that area that's damaged, all right? Or that has a tumor, right? Now, the pia, the dura, that will heal, right, by itself. So that part's okay. Right? Now, besides that, this arachnoid mater, right? We're going to see that, and it's probably easiest to see with a picture right here. All right. So on this picture right here, here's a cross section of our cervical vertebrae, right? Over here, we have a little bit of subcutaneous fat. And then we have all right, over here in kind of brown, this real thick piece of dura mater, dense, regular connective tissue that covers the brain and the spinal cord entirely, right? It acts like a secondary bone matter, but it's much smoother and more malleable, right? So this dura mater right here, loose, fitting sleeve around the brain and the spinal cord, right? Tough collagenous membrane surrounded by epidural space filled with fat, right? This is an area where we'll do a spinal or epidural anesthesia, right? So over here, the dura mater itself covers the outside of the brain and the spinal cord, right? So when we talk about the brain, it's continuous with the spinal cord as well, right? So let's take a look what we mean here. So right here, we have the dura mater. Notice that it completely covers the spinal cord in the middle, and then it actually covers the spinal nerves as it exits out, right? So the dura mater covers everything. The brain in the skull, right, goes down. The dura mater then goes down the vertebral column, covers the spinal cord all the way down the vertebral column right here. And it also covers the spinal nerves as it exits out of your vertebrae and into your target tissue, right? So you have this dura mater that covers when the spinal nerve exits out. Now, when sometimes, right, when we're outside of the dura mater, we call it epidural space. So when women are giving birth and they need a epidural, what we do then is near the spinal cord area in L3, L4, right? We have a woman kind of hunched over, right? In a second, I'll show you why we want them to be hunched over in a C-shaped position, right? And then we take a really big needle and we put that needle into the area that's outside of the dura mater, right? As it goes outside the dura mater, you release the lidocaine here, and the lidocaine follows the dura mater and covers the spinal nerve in that region, numbing the spinal nerves in that region so you don't feel pain signals. Perfect. You never go into the spinal cord though, right? Now, sometimes when you're doing that, they'll give you a little informed consent, right? Where they ask you and they tell you, do you want to keep doing this? Because there's a chance that I might, and the anesthesiologist, because it's a long needle, there's a very small chance that the needle will go through the dura mater and into this arachnoid mater, right? And through it. The reason why they say that is usually when that happens, you release the lidocaine into this area on the inside now of the vertebral column, right? You still have the numbing, so you don't feel any pain, but, right, usually because you cross through the dura mater and the arachnoid mater, a little bit of cerebrospinal fluid can leak out, right? And then you have what we call a spinal headache that can happen because cerebrospinal fluid can leak out, and now you have less CSF than normal, and it can cause people to have tremendous headaches, really bad ones. Yes. No, no, right. So this epidural we do when we're not going to do it before shocking because that'd be too much. That'll be global, right? So when we do epinephrine, right, that's usually part of lidocaine, right? And what it does, it causes constriction of the blood vessels. Here we're talking about lidocaine that we release into this area. We're not worried about, there's not a lot of blood vessels out here. We're not worried about any kind of blood vessels. Epidural and no, be careful, all right? Because we use epidurals and epinephrine, right? Epinephrine we call epi. We never call the epidural epi, right? Because it's just too broad, right? So that's usually when we're trying to give somebody some kind of injection, right? Some kind of numbing agent for that area because we're about to cut through, right? So it decreases the amount, right? So we put lidocaine in something, that'll numb it, and then we put epinephrine in there to control the bleeding, right? Because we have to cut through that tissue. Now, the arachnoid mater right here. So nodal maters, and I'll show you a better picture of it on Anatomy and Physiology Revealed, right? The arachnoid mater is a membrane consisting of simple squamous epithelial cells, and it lines the dura mater, right? Now, in utero and in our body, in vivo, what we're going to see is that we have cerebrospinal fluid deep to the arachnoid mater, right? So this cerebrospinal fluid right here is found deep to the arachnoid mater, and it's going to fill that space between the arachnoid mater and the pia mater, right? So over here, I'm just going to write this down. This CSF, right? So let's take a look, right? Take a look at what I mean right here. So when we actually trying to do a spinal tap, right? When we're doing a spinal epidural, we don't want to go in past the dura mater. We want to be outside the dura mater in this fatty area. That's perfect, right? But when we want to do a lumbar puncture, a spinal tap, we actually have to go through the dura mater, go through the arachnoid mater, and into the space. Do you see this pink right here? The pink area is actually the outer covering called the pia mater. And it covers the brain, covers the spinal cord as well, because it's continuous, right? And that space between the pia mater where it ends and the arachnoid mater in light blue that we see here, that space is filled with cerebrospinal fluid, right? So in order to do a spinal tap, we actually have a needle that has to go through, right? Goes through the epidural, then it has to go through the actual arachnoid mater, right? And then go into this small little space called the subarachnoid space. That's where the CSF is formed, right? That's where we find the cerebrospinal fluid. So when somebody we think has meningitis, right? Well, the cerebrospinal fluid is continuous with the brain. So what happens? We don't need to go to the brain to check if there's an infection, right? We go into the spinal cord, which is dangerous enough. So in that area right there, what we do is we take the baby, usually babies are more likely to have it, put them in a C-shaped fetal position. We put this really long needle, insert it in a between L3 and L4, right? It's much safer there, right? And then we put a needle that has to go through the dura mater, through the arachnoid mater, and into the space between the arachnoid mater and the pia mater. So into the space between the arachnoid mater and the spinal cord, right? If we do it perfectly, we don't touch the spinal cord at all, right? Why do we do it between L3 and L4? Because between L3 and L4, you don't have a true spinal cord anymore, all right? It's not thick cord anymore. You have these nerves that exit out, but they're allowed to move out. They're not bundled tight anymore. So even if I hit a nerve, there's a lot of room for that nerve to move out of the way, right? Yes.
I know that people do it when they're trying to figure out what disease you have in the past. Is it always very?
No, not certain diseases, right? We can test for MS, right, as well, right? That kind of disease. We can check for, right, certain diseases, but not a lot. This is usually what we do it for, is we think you have some kind of meningitis. And because we think you have meningitis or encephalitis, we're going to do a spinal tap, right? We think you might have West Nile. We think you might have bacterial meningitis. We'll do a spinal tap for that because bacterial meningitis is incredibly dangerous. So we need to find out, right? Now, the pia mater itself is delicate and it follows the contours of the spinal cord. So it covers the brain and spinal cord. And I want you to think about this, right, as like a right plastic wrapping, a saran wrapping around the brain and the spinal cord, right? Now, anybody's ever gone and got some cake and a wedding cake, birthday cake, and then you want to kind of save it for later because they make you buy like large amounts, right? So you always have too much of the birthday cake. So what happens then? You save it, you put it, and you wrap it with saran wrap to keep the actual frosting nice and moist, right? Well, once you remove that saran wrap, all of the frosting comes with it. So I want you to think this pia mater is like this saran wrapping that's covering the brain and the spinal cord, right? If you remove the saran wrap, you will damage the brain and the spinal cord because it's so intimate with it. Now, the pia mater has areas, right, that are special. One of them is called the phylum terminalis region, right? Now, we said that the spinal cord itself ends between L1 and L2, right? Now, that doesn't mean you don't have nerves still, because we have nerves that has to go to our legs, right? In the lumbar region. But the actual nerves that exits out are no longer bundled tightly as a cord in that region. Now, what we're going to see is you need to anchor the spinal cord in place. One of the ways we anchor the spinal cord in place is through the pia mater. So at the very end of the spinal cord, you have a piece of this meninges that goes down and anchors it to the, right? Anchors it to the coccyx right there, right? So it's really important. I'll show you what it looks like on the actual model. This model doesn't show it because it only shows a cross section. In order to see the phylum terminal, we're going to need to see a longitudinal section to see it, right? Now, in terms of spinal cord, we have gray matter and white matter. Gray matter are areas of the brain and the spinal cord that has a cell bodies. They look gray because there's no myelin sheathing, right? Myelin is made out of fat. Fat looks yellowish white, right? So anything that's covered with fat will be just about yellowish and white. Here, right, the cell bodies don't have the myelin fatty sheathing. Because of it, it doesn't look white. Instead, it looks gray. By the way, that's why we say we have a lot of gray matter in the brain. It's a sign that we have a lot of cells in the brain. More cells, hopefully more intelligence, right? White matter is slightly different. White matter, myelinated axons, right? So these myelinated axons right here will then carry signals from one neuron to the next. That's part of a pathway. So that we can carry a signal from one area of the brain to another area of the brain, or one area of the brain to the spinal cord, right? Again, myelinated axons are the processes that allows you to connect to other cells, right? Now, in the spinal cord, the gray matter itself is going to be arranged like an H, right? Or it looks like a butterfly. So you have this gray matter right here, full of cell bodies. And again, if the cell body of a neuron dies, the neuron dies. There's no recovery, there's no regeneration. It is only the white matter that we can regenerate, right? So if the neuron dies, you can't regenerate it. But if the neuron cell body is alive, but part of the axon is damaged, you can regenerate that axon, right? You can recover it. Again, spinal cord, the gray matter looks like an H in cross section, right? You have a pair of what we call dorsal horn. That's this area over here, right? Then you have dorsal roots or posterior roots, right? I like using the word dorsal more than posterior, right? The book usually uses that word, right? So you have the dorsal root, R-O-O-T, and then you have ventral root, R-O-O-T. Now, these are going to be important for a reason, right? Posterior or dorsal horns, right here, contain cell bodies for sensory neurons, right? So we're going to send, when you have any kind of a sensation from your fingers, we're going to send the signal all the way into the spinal cord. As it goes into the spinal cord, right, it enters the spinal cord through the spinal nerve. And then the signal goes towards the back. And we direct all sensory signals dorsally towards the back. All sensory signals then moves towards the back. Then it synapses with a second neuron found in this dorsal horn. right? Then that second neuron sends a signal up the spinal cord to your brain on the opposite side, right? This is how we carry information from your limbs to your brain, right? Again, what did I mention? All sensory signals, when we get close to the spinal cord, we separate. Sensory signals move towards the back, right? All sensory. So in this region right here, there should be no motor signals. Now, motor signals always move out towards the front or ventrally, right? So we have motor signals that move out to the front. The cell body of those motor signals are in the anterior or ventral horn, right? So again, dorsal horn, sensory neurons, right? Cell bodies. Ventral horn, cell bodies for motor neurons, right? So again, all right, ventral is always motor. Cell bodies of the sympathetic nervous system are fight, if I'm working out and I need to increase my heart rate, right? What we're going to see is that we have a, right, on the kind of edge right here, we have a lateral horn group of cells that will activate. As they activate, they have motor signals that move out through the front, through the ventral horn, right? Through the ventral root, goes out through the spinal nerve, and then goes to my heart. In the heart, it'll cause my heart to increase the heart rate, right? And again, keep in mind that we have a separation here, right? Skeletal muscles, when we want it to work, well, that's voluntary, right? We control when it activates. The heart, when we want it to work, is involuntary. But that doesn't mean you don't have control. It just means that it's subconsciously controlled. Subconsciously is controlled by cells that are found in the lateral horn. Right? White matter in the spinal cord. The white matter in the spinal cord surrounds the gray matter and consists of bundles of axons that goes up and down. All right. So the white bodies right here are going to carry sensory information up to the brain and the spinal cord. It's going to carry motor signals downwards from the brain down the spinal cord, then it synapses, right, and then carries it to the target muscle, right? Now, we're going to see that there are three pairs of columns of white matter that are ascending, right? So some of these ones I want you to know specifically which ones we're going to go through in just a few minutes, right? So we have these kind of up and down movements, right, of information up and down the spinal cord. And whenever I say up, I want you to think about all the movement, all that information goes up the spinal cord. They're almost always sensory signals because we need the brain to process all those sensations, right? Then once the brain processes all the sensations, then it'll trigger movement down the spinal cord. So motor signals are going to go down the spinal cord then. So here we see ascending tracks or signals or pathways. Those are all types of sensory signals, right? When we find it in the limbs, right, they're found in the posterior region. This is where we get the signals from your limbs, right? The gracile fasciculus right here. That's going to carry signals from your legs, right? Sensory signals from your legs. Your cuneate fasciculus is going to carry sensory signals from your upper limbs, fingertips, hands, arm, forearm region, right? So we kind of figured out what the spinal cord and how and where they carry certain information. If we carrying sensory information from your upper limbs, they enter the spinal cord. And again, sensory information needs to go up into the brain, right? How does it go up to the brain? It goes up by creating the cunate fasciculus, right? As part of the dorsal column, right? In your foot, right? Information from your foot helps form the, right, the gracile fasciculus. So what we're going to see is that in the cervical region, we're going to have a large amount of information coming from limbs upwards, large amount of information coming from hands upwards, right? For the brain to interpret. So everything in red right here are types of sensory information that has to go up to your brain. Everything in green right here are types of motor signals. It's either going to go to your target skeletal muscles or it's going to go to your smooth muscle in your GI tract, or even your heart, right? So when we talk about fasciculus or tracts, these are pathways, right? Pathways for certain type of signals. So what type of signals? Again, ascending tracts very generally. Understand that ascending tracts carry signals that are sensory. Descending tracts carry signals that are motor, right? Simple question I can ask on the upcoming tests, right? In a couple months, in about a month or so, right? Next test is going to be primarily focusing on the joints and the muscles, right? This one will be in a couple weeks after that, right? So descending tracts, if I ask, what do descending tracts carry? Right away, I want you to think, well, brain process information, then figures out what to do with it. It does so by activating tracts that descend downwards from it, causing some kind of a motor activity, right? Ascending tracts, well, it's ascending because we want to bring sensory information for the brain to process. It doesn't have to be, right, external sensation like sight, smell, touch, right? It can be something like internal sensation where you're hungry, right? And your stomach starts to grumble. That's a type of sensation as well. And that has to ascend to your brain. And then your brain tells you, you better get some food, right? So yeah, we do have these tracks and they cover internal and external environments. Decussation right here, know what these words mean because we use them a lot. Decussation is a fancy word for saying crossing over. That's it. Cross over. So, right, the left side of your brain controls all the muscles on the right side of your body. What happens? The motor neurons of the brain, as it goes down the brainstem, it crosses over or decussates. As it decussates right here, it crosses over and then it synapses with the opposite side of the spinal cord, causing the second motor neuron on the opposite side of the spinal cord to activate the muscle on the opposite side of your body. All right. So decussation is a fancy name of saying a crossing over effect, right? So if you have a stroke right up here in the temporal lobe region, you're going to have paresthesia, right? Loss of sensation on the right side of your body. You're going to have paralysis on the right side of the body, right? If you have a stroke on the right hemisphere of the brain, right here in the temporal lobe area, you'll have paralysis on the left side of the body. It's always contralateral, or, right? And it's contralateral because it decussates. Contralateral means opposite part of the brain and the spinal cord, right? So contralateral, origin and destination of a tract are found on the opposite sides of the body. So what is a way of saying it, right? The left hemisphere of the brain activates a contralateral side of your body, right? Opposite side, right? So contralateral just means opposite. Yeah. Right. Face too, but right in the face, you don't have to usually cross over. Right. Ipsilateral means same side. Same side. So right? In the face, it's a little different for the muscles, right? Because you don't have a spinal cord to cross over. So it's usually ipsilateral. So the main cranial nerves we'll talk about. Some of you might have heard of facial nerve palsy, right? With facial nerve palsy or Bell's palsy, right, usually what happens is your muscles that control your facial expression, the muscles are controlled by the facial nerve, right? And when you have Bell's palsy, one of the facial nerves, either the left or the right one, is paralyzed for some reason, right? And it's an ipsilateral kind of a damage, even though it's not truly damage, right? So if you have the right facial nerve that's affected, then the right hemisphere of your face is affected, ipsilateral side, same side. That's all ipsilateral means, same side. All right. Ascending tracts. Remember, all neurons on all sensations need to travel up. So if you have a pain reflex, right, you cut yourself while you cut your finger as you're cutting onions, right? What happens? What happens is that pain signal needs to enter the spinal cord. It takes 3 neurons as part of a pathway to send a pain signal into the spinal cord. Then a second neuron sends a signal up the spinal cord, crossing over, and it goes to the thalamus, a certain region of the brain. A third neuron then sends it to a specific part of the brain that is for your middle finger, right? What we're going to see is this. We have mapped this out, and it's kind of cool, right? When somebody is in some kind of neurosurgery, the last thing we want to do if you have a tumor is take out too much of your brain. So then obviously you can't recover, right? So what we usually do is when somebody has neurosurgery, brain surgery, right? We put them to sleep, we cut through the actual skull, we cut through the dura mater, and then we slowly decrease the amount of anesthesia. So then they're partially awake, right? As we partially awake, they're going to actually stimulate certain areas of the body, right? And sometimes when they stimulate the prefrontal cortex, the prefrontal lobe area, right? When you stimulate that area, the finger moves, right? That's why we can tell that the opposite area of the brain controls the opposite area of the body, right? Sometimes when it's deeper, it's even crazier. So if you have a tumor deep into your brain, we want to make sure we get the tumor, but not the good brain matter. So they will stimulate certain parts of the brain, right? In the temporal lobe area that's deep, right? Sometimes you cause that person not to move their finger, but to relive a memory, right? Because memories are part of a pathway that we embed. And right in front of you, they relive the memory to the point where you think they're just almost imagining it, but they're reliving it almost visually in front of you. They can tell you how it smells, how it tastes, how it feels, right? In real time as you stimulate that pathway. Kind of crazy, right? They're awake, right? Remember, your brain matter has no pain receptors, so it doesn't hurt. Everything else leading to the brain does have pain receptors, scalp, skull, even the dura. But once we get to the true brain matter, there are no pain receptors. So we can stimulate it without causing pain, right? That's a crazy part. Is you can actually help them relive a memory where they're smelling something. And they're like, and they smell it, right? And they really smell it right in front of you. And you know you're in an OR, so they shouldn't smell anything, but they do. Yes. You guys know that most headaches, we don't know the cause, all right? Migraines, we don't know the cause. We think it has to do with a vascular issue, right? Well, in the blood vessels of the brain, they do have pain receptors. And we think that, yes, it is something to do with the actual blood vessels in the brain, not the brain matter itself, right? That's why most of the medicines are there to vasodilate, right? The blood vessels in the brain. Sometimes they vasodilate other blood vessels. That's why you feel kind of uncomfortable after taking it, right? Now, with these neurons, right? The first neuron is always called the first order neuron. They're the ones that detect any kind of stimulus and brings that action potential into the spinal cord. The second neuron carries that action potential from the spinal cord to your brain, right? Usually, there's a special part of the brain called the thalamus, right? The thalamus is our operator. You guys don't even know what an operator is anymore, right? Now, I want you to think about what an operator is. An operator is somebody back in the old days, right? When we first got telephones, right? Anybody has a landline still? At home, a landline, right? Where you have like a cable phone, right? Most people just have cell phones now, right? And they don't even have a landline at home. But 100 years ago, when we first started having telephones, only the very rich people had telephones. And those telephones had physical wires that connected their phone to, right, AT&T or some kind of, Pacific Bell, some kind of telephone company, which is crazy, right? There was actually a physical connection between your phone and then a copper wire will link it to AT&T. In AT&T, right? What happens? You have a person there, right? That person, right, will actually connect that wire from your house to the next person you want to talk to. And now you have a complete circuit of wires, right? And because we have very few people with phones, they're able to just kind of use it and, right? I want to talk to this person, right? So they have this phone number. They look at the phone number, they'll connect the two wires. And now you have a complete connection here, right? Well, the thalamus is our operator. It's the one that connects that message coming up to a specific area of the brain that's going to process that information from that specific region of your body, right? The weird thing is this, we have mapped it out, right? Your precentral gyrus, there's a specific area of the brain where all sensations coming from your limbs, right? All those sensations end in that region, right? Now that region isn't, right? If you think about it, it kind of makes sense, right? It's not very, how do we say it? All right. It's not very localized, right? It's what we'll say, it's like there's certain parts of your body that has greater room, right? So your fingers, because we touch and feel, right, things with it, there's bigger area of the brain for sensations of your fingers, right? Why? Because that's how we are able to connect with the environment. Now, your GI tract area, there's very little area of the brain for it. That's why it's so hard for us to localize pain when your abdomen is cramping and you have diarrhea. Is because the actual region of the brain to process all the signals from your stomach, from your small intestine, from your large intestine, from your kidneys, all right? All those internal viscera, right? There's a lot of them and it's pretty big, right? Pretty large room. Well, all that area, right? Well, all that sensation from those areas, they all go to a very small region of that precentral cortex, right? That region is small by about 3 times the region for our fingertips, right? Even though our fingertips are really small, right? Compared to how much room we have for our abdominal viscera, right? So the second order neuron connects us to the thalamus, which is an operator. The third order neuron then connects it to a specific area of our cerebral cortex, specific for that limb, right? So just know that it takes 3 neurons. First one sends it in, second one sends it up, last one sends it to, right, a specific area of your brain to process, right? Right. So what are the major ascending tracts and what are the major descending tracts? Whoops. All right. So descending tracts we'll talk about, and some of the ascending tracts we'll talk about as well. Let's take a little break here, and then we'll finish up. All right, so let's finish up here. We're going to talk about some of these. Just understand what is the difference between the motor tracks that are ascending, that are the major tracks that are ascending, and then the descending ones that are motor tracks, right? So this can be a good, what do we call it? Good kind of note card material because it's so small and pinpoint. Tectospinal tract, right? What does it do? Reflex of turning head in response to sight and sounds. Example of this, right? You hear a loud bang. Right away, you turn your head to it, right? So that's a reflex that allows us to kind of locate where that sound is coming from. And of course, you're probably wondering, why do we have this reflex? Simple. Remember what I said, as we evolved, right? We didn't always have guns. We didn't always have spears. We didn't always have bow and arrows, right? So what happens? We weren't always the alpha kind of, animals, right? So if you're part of a group and you hear a loud sound coming at you, you want to be able to localize it first, right? And run first so then you can get away, right? So you have two choices: have very slow friends or be the first one to actually see it and run away first, right? That's the reason why we have this tectospinal tract. So you can locate something that might be coming at us, right? Lateral and medial reticulospinal tracts allows us to have muscle tone for posture and balance, right? So reticulospinal tract, just know it as reticulospinal. What is it for? Posture and balance, like control of limbs, upper and lower, right? Vestibulospinal is for balance and equilibrium. Now, anytime you have the word vestibulo, right? Vestibular, that's always something to do with balance and equilibrium. So this vestibulospinal tract receives impulses from the ear and allows us to have balance so then we don't fall over, right? Now, one of the things we can actually do, right, because have you guys ever had an ear infection and then your balance and equilibrium gets all messed up, right? Well, it's because of this vestibulospinal tract, right? The signals gets kind of crossed when that happens, and your brain kind of doesn't know where your head is, and you get kind of dizzy, right? Now, we can also activate and kind of get this tract a little bit fuzzy, right? Mess with it a little bit when we drink too much, right? And yes, it can be part of it, all right? Definitely. Motion sickness, right? And us and kids usually, right? That can cause this kind of activation of this tract and then cause nausea as well, all right? So again, tectospinal, reticulospinal, vestibulospinal, all right? Tectospinal, reflex of turning your head in response to sights and sounds, right? Reticulospinal, balance and equilibrium, right? For posture. Vestibulospinal is, that's reticulospinal. Vestibulospinal from your inner ear, so then you don't fall over, right? Now, in terms of general anatomy, when we look at a nerve, whether it's a spinal nerve, whether it is our name nerves, like your median nerves, understand that the nerve are multiple axons bundled together, coming from similar areas, carrying similar messages. Those bundles are then like you have one axon, then you bundle it with 1,000 other axons. We call it a fascicle of them then. A bundle of them is a fascicle, right? Next to that, you have another fascicle and then another fascicle. All right, so if you have something like the median nerve, you have all this information coming in from your middle finger, your ring finger, and your index finger. All the sensations for touch, pressure, tickle, itch, pain, all those sensations here, right? Well, there's a lot of area in your fingertips, a lot of sensitivity there. So what we're going to see is that each axon is bundled next to another one, bundled next to 1,000 other ones, becomes a fascicle, and we have other fascicles that kind of bound together to form an actual nerve, right? So for right now, just understand a nerve is a lot of different axons, right? Not just one, right? So a nerve, cord-like organ, composed of numerous axons that are bound together by connective tissue. The mixed nerves are going to be combination of sensory and motor signals. Right? We say they're mixed because they have both sensory and motor, right? Nerves of the peripheral nervous system are ensheathed in Schwann cells, often forming a myelin sheathing around the axon, right? A fascicle is nerve fibers that are gathered in bundles. So a better way of understanding it is actually seeing the picture. So we'll come back to that in a second, right? So right here's the picture. So here's what your spinal nerve as it exits out of our spinal cord, right? When we get close to the spinal cord, we separate. So that when we get close to the spinal cord, all right, what we're going to do is separate the sensory signal goes towards the dorsal or backside of the spinal cord. Motor signals come out in the front, right? But that only happens when we get close to the spinal cord. When we move away from the spinal cord right here, right, what happens is we mix those signals. So if we were to cut right here, take a cut of this, cut right here, what we'll notice is that all the sensory signals are back here, all the motor signals are in front, right? Makes sense, right? But if we make a cut right down here, right? If we make a cut right down here, we got to mix everything up. So we look at the front area of that nerve, right? That's carrying sensory and motor signals. If we look at the back part of the nerve, it's carrying sensory and motor signals. It is only as we start to get into the spinal cord do we separate the signals, right? So just keep that in mind that we have the separation of signals as we enter the spinal cord. But as we exit, we mesh them all together, right? Right. So here's the spinal cord and what it looks like. So we have 31 pairs of spinal nerves that exits out of the spinal cord, right? The spinal cord is going to bundle all 31 pairs, right? From your cervical region to the lumbar region, we bundle it tightly into a cord, right? Then between L1 and L2, we let the actual individual nerves move outwards, right? So again, spinal cord is made out of these fibers coming from these spinal nerves, right? Above the lumbar vertebrae, right? We tightly wound all those nerves together. As we tightly wound all the nerves together, it becomes a really thick cord, right? Maybe not too thick, but it's really tightly woven cord, right? Made out of spinal nerves, right? As we go down, we just let the nerves free, right? As we let the nerves go free, what happens? With individual nerve fibers that exits out here, right? If we hit it with a needle, right, there's a lot of room for the actual nerve to move out of the way. Now, in my 201 class, I actually use an analogy. Have you guys ever tried when you're cooking spaghetti, right, or noodles or pasta? Have you ever tried to pick up one little bit of a spaghetti, one strand of it, to taste to see if it's done? It's really hard, isn't it? Right? You're using it, you're like, oh, I'll use a fork. And then you try to use a fork, and it's really hard to pick up. It just slides off, right? Well, that's what's happening here, right? I want you to think of your spinal cord as these noodles, right? On top over here, that's like what happens when you take the noodles out and you strain it, right? As you strain it, they're all bundled tight together, right? Easy to pick up. As we move down, the noodles are what happens when they're still in the water, right? You still have the noodles, you still have the nerves, but what happens is there's so much water surrounding it. When you try to pick it up with a fork, it wiggles out of your way. That's perfect if we want to get a spinal tap. Because if we accidentally hit one of the nerves with a needle, it's able to move out of the way. Perfect. I don't damage that nerve. But what if I were to do it up here, right? If I would hit the cord, the nerves over here, are bundled tight. It can't move. So if I hit the cord, what happens is the needle will go through the cord, and because the nerves can't move, I will go through the nerves, all right, and cause you permanent damage, right? That's why when we do a spinal tap, we always go in the lumbar region. So then we minimize the risk of causing damage to your nerves and your spinal cord, right? Because at L1, L2, your spinal cord stops being a spinal cord. Instead, we just have the spinal nerves exit out and they're free to move around in a vertebral canal. So if we hit it with a needle, it's free to move out of the way. There's no other nerve next to it, all right, bundled tight next to it. So then you can't move, right? So then that nerve can't move. So it's free to move. Perfect. We call this area right here the area of our cauda equina, right? The cauda equina right here means horse's tail, right? If you've ever seen a horse's tail, it ends physically and then hair still comes out of it. That's what we see here. The spinal cord ends and then hairs still come out, right? The hairs are the nerve fibers that still come out, but they're just no longer tightly wound as a cord anymore. Right. So here are the spinal nerves that exits out. Here's a spinal cord that allows these nerves to go out and in, right? We have 31 pairs of spinal nerves. We have a dorsal root or a posterior root. I usually use just dorsal, right? And again, right, when we go enter the spinal cord, we separate the signals, right? When we're away from the spinal cord, we mix the signals. So here we're really close to the spinal cord, right? We're going to then separate the signals at this point, right? So as we get close to the spinal cord, we separate. All the sensory signals goes dorsally. All the motor signals exit the spinal cord ventrally, right? So in the spinal cord area, motor signals comes out to the front ventrally. In the spinal cord, all sensory signals go towards the back dorsally, right? So dorsal is sensory, ventral is motor, right? And the easiest way to remember is this, right? Dorsal, dorsal is sensory. Ventral is motor. All right, so there's a T in ventral, T in motor. I keep losing my. There's an S in sensory, S in dorsal, right? Right. So know what is dorsal root, what messages it carries? Sensory signals. The ventral root, motor signals, carries out the spinal cord to your target organ, whether the organ's your arm muscle or your GI tract, all right? Right. Now, besides anterior root or ventral root, right, we also have ventral and dorsal ramus, right? I'm going to use ventral and dorsal instead and right here, right? Now, here we have the spinal nerve that exits out. As it exits, right, it separates. It separates into ventral ramus and dorsal ramus. So why am I mentioning this? This is after we form the spinal nerve. This is away from the spinal cord, right? Remember, as we move away from the spinal cord, we mix the signals. So when we talk about ventral and dorsal ramus right here, these are mixed signals, right? They're going to have sensory signals, right, from the skin and the muscles, right? They're going to receive sensory signals from the skin and lateral aspect, right, of the skin area, and motor signals to the trunk, right? So for now, I want you to just understand that ventral rami are mixed and it contain, and I'm going to write it down, contains signals that are motor and, whoops, sensory, right? So don't get ventral ramus and ventral root mixed up. Ventral ramus exits out and it's going to go to the front of our body, right? At this point, you have sensory and motor signals here, right? Same thing with dorsal ramus. Dorsal ramus exit out of your spinal nerve. As it exits out, it's going to go towards the back and it's going to also be, right, a combination of motor and sensory signals. Ah, right? So both are going to have motor and sensory signals because this is outside of the brain and the spinal cord segment right now. All right. Again, dorsal ramus is not the same as dorsal root. Dorsal root is only found as we enter the spinal cord. Dorsal root only brings in sensory signals from your body, right? Dorsal ramus is further away from the spinal cord where we haven't separated yet. So the dorsal ramus is going to carry messages for your muscles of your back. Is going to receive sensory signals from your posterior areas of your back as well, right? So it's going to carry both motor and sensory signals. The rami are, all right? So let me see if I see a good picture here. Right? So here they just kind of show you the difference between the ventral root. Here's a spinal nerve segment right here. Right? Right. All right. Just understand ventral ramus, all right, comes from the spinal nerves. The spinal nerves exit your vertebrae. And as it exits, it separates. As it separates, it turns into the ventral and the dorsal ramus. And since we're far enough away from the spinal cord, all right, the ventral and the dorsal ramus carry both sensory and motor signals to your limbs from your limbs, right? Now let's talk about what happens with these ventral rami, right? The ventral rami of multiple regions, they branch and network. That's what anastomose means. They network, right? Repeatedly to form what we call nerve plexus. Now, the cervical plexus, I want you to be able to note what they are for the lab practical. And for the test, understand what it does. It helps form the phrenic nerve. Phrenic nerve goes to the diaphragm, right? There's a saying that you guys will hear if you're going to be nurses or in any medical field. C3, C4, and C5 keeps you alive. What that means is, right, if you have an interruption of the spinal cord above C5 at either C3, C4, C5, right, that means that you can't bring signals through the phrenic nerve anymore. When that happens, you can't move your diaphragm. And now again, you're part of that. You have to make that really, really terrible choice, right? Do I want to be paralyzed below my neck, have paresthesia below my neck, loss of sensation, and have a ventilator for the rest of my life, right? Now, I say this, right, when I was in, and this is a small world, right? So what happened is I told this story about 10 years ago. right? And I had immediately a student raise their hand and they asked me if, the name of this person. All right. And it was the same person I was talking about. In high school, I was a wrestler and I was a sophomore. The kid that I used to wrestle with was a junior, really big heavyweight, right? As I was wrestling, they had a wrestle off to see who would be on varsity. He was a heavyweight and he was wrestling with another heavyweight, right? When we come back, everything was just in chaos, right? What happened was they were trying to do a throw, right? And my friend had landed on his head, right? At the age of 16, he had severed his spinal cord above C5. He stopped breathing on the way to the hospital, right? And from that point on, so this was what? He's 16, he's now like 51, right? From that day on, he's been paralyzed below the neck and have no sensations below the neck. The only thing is he got lucky because he should be in a ventilator, right? Because it was above C5. He was able to kind of work it out, right? Recover some of the function so then he can breathe by himself, right? But he's still paralyzed below the neck and still has loss of sensation. Now, that doesn't mean that he doesn't have a good life, right? He graduated from Madison. He went to law school. He's a big advocate for, Americans with disabilities, right? At the same time, you could still see some like Facebook posts that get really dark, right? Gets really dark. And he's able to type with his mouth. He's able to, right? He has a keyboard that kind of you can move his head and use his head as a, kind of as a cursor, right? But it's hard, right? And what happens is the reason why we have this saying is because any interruptions above C5, your phrenic nerve usually gets, right, also damage. And now you can't move your diaphragm by yourself. You can't breathe by yourself. That's brutal, all right? So that's the cervical plexus. The brachial plexus are going to supply motor neurons and sensory neurons from the limb and the upper body. So all of the nerves that we'll discuss this afternoon and next week, right? Well, those nerves of your upper arm, lower arm are all comes from our brachial plexus. Now, what is the brachial plexus? Is going to be, here's our cervical plexus, right? Here's our spinal nerve right here when it exits. When it exits, right, part of the ventral rami mixes with the ventral rami of other spinal nerves to form named nerves. Here, with the phrenic nerve, right, you have a branch of the ventral rami from C5. That helps form the phrenic nerve. But that's not it. That's not all. You also have part of C4. Their ventral rami adds to that mix of signals. And part of the C3 add to the mix. So you have branches of all three from C3, from C4, from C5. All three of them help form the phrenic nerve, right? So if any of them get damaged, you're not going to have the phrenic nerve being active. And without that phrenic nerve being active, you can't mobilize a diaphragm. All right. So when we talk about cervical plexus or any plexus, it is nerve fibers that come out from multiple regions that network and mixes with other nerves so that we form a larger nerve, right? So in the cervical regions, know the phrenic nerve. For the brachial plexus, right? Brachial plexus are a little bit lower down, right here. The nerves are going to be found in the upper arm area. So your radial, median, musculocutaneous nerves. These are the three nerves that we will see that we will need to know for our lab practical. And again, with these, right, we don't have to worry about locating them for the lecture exam, right? It's only for the lab practical. For the lecture exam, right, what do I want you to know for the brachial nerves? Or brachial plexus, right? They supply motor signals to your arms, right? They receive sensory signals from your arms. Right? Now, from the lumbar plexus, right? Lumbar plexus over here, they form the femoral nerve, right? Right here, femoral nerve. Now, right? Be careful because part of the lumbar and the sacral plexus forms the sciatic nerve as well, right? But when we look at the femoral nerve, its entirety helps form this femoral, right? The lumbar plexus right here coming out only in blue, right? They form the femoral nerve. So again, right? For the test, lecture exam, no lumbar plexus goes to the femoral nerve. Femoral nerve is in the front of your leg, right? Any muscles in the front, like your quadriceps muscles, they're all activated by that nerve because where the nerve is found, it goes and gives motor activity in that region. Anterior thigh, abdominal wall, genitalia, right? Actually, the anterior thigh is a big one right here because it is part of the femoral nerve. The sacral nerve and sacral plexus helps form the sciatic, right? Anybody has sciatic nerve issues? You guys are young, but as you get older, you might, right? Have sciatic nerve issues. You might have it when you get pregnant too, right? So what we're going to see with the sciatic nerve over here, there's a good sciatic nerve, right? The sciatic nerve is formed by the lumbar and the sacral plexus. The sciatic nerve is a nerve that goes to the back of your thigh. So your hamstring muscles, right, is going to be innervated by your sciatic nerve. Your calf muscles, sciatic nerve. Your anterior part of your lower leg is also sciatic nerve, right? Your sciatic nerve goes all the way down to your pinky toe. All right. So then if you have an issue with your sciatic nerve, you're going to have issues in your hamstring, really high up, all the way down to your pinky toe. Sciatic nerve issues suck, in other words, because there's so much of your muscle that actually is innervated by the sciatic nerve right here. All right. So again, and we'll go through it as we go through some of these models, right? It'll make a little bit more sense because it shows where the actual nerve is in kind of, right, how it's close to those muscles that we're going to mention. All right. I will stop right here. And we will take our break.